commensurate fewer number of health workers that man these health facilities. Then a combination, of course, of both socioeconomic, political factors and COVID-19 have been part of what has worsened the major health indicators in the state, and of course the ongoing humanitarian crisis. And then also the high ratio of maternal, infant, and under 5 mortalities and a lot of outbreaks. The state health system is declining. As such, many of the inhabitants prefer to reach out to the private institutions rather than go to public health institutions. And donors have supported in the last 5 years over 100 billion naira to support the health system in the state. And then the health sector performance indices are suboptimal, which may likely pose threats to achieving universal health coverage in the state. So let us look at some WHO strategic pillars towards attainment of the universal health coverage. Looking at the strategic pillars, of course, the first and the foremost is to promote an enabling environment for attainment of health sector goals, strengthen health system for delivery of essential package. I saw Prof give us some part of the essential package that we need, not just during crisis, but even at normal times. Then increase utilization of essential package of health service delivery packages, and then protection from public health emergencies and risk, as well as increased sustainable financial and health and risk protection. Now, the strategic approaches by WHO to all states and member states is that the overall national agenda includes sustainable framework for primary health care, of course, within the context of UHC, and then the Basic Healthcare Provision Fund, which I'm happy that there are a lot of positives coming from that BHCF in Plateau State, and then, of course, to strengthen coordination and quality of health services, as well as establishment of health insurance scheme and social health investments in the state. Of course, to enable legal and policy framework for PHC revitalization, as well as strengthen capacity of response to the healthcare system. And also collaborate with global, regional, national, and network support to improve the level of care of people of Plateau State. And then establish operational research initiatives and research models. So these are what we need in terms of improving our strategic approach to having universal health care in Plateau State. Some of the national key priorities include leadership and governance, which we have seen, of course, by the governor supporting this program. So I think that is commendable. Then community participation and ownership, very important. Partnerships for health, we are seeing a lot of donors and partners here. Of course, improvement in terms of reproduction, maternal, newborn, child, and adolescent health is one key priority in order to achieve universal health coverage in Plateau State and other states as well. Communicable and non-communicable diseases, general and emergency hospital care services, health financing, of course, human resource for health, health infrastructure, build of medicines, vaccine, and other health technologies and supplies, health information system, research for health, public health emergency preparedness and response, and of course, the last but not the least, health promotion and social determinants of health. So colleagues, these are our building blocks and key priorities for us to be able to achieve universal health care system in Plateau State. So what are the proposed health system reforms towards achieving this system? Like I said earlier, leadership and governance, which includes strategic policy frameworks, coalition building, regulation, as well as accountability. I was happy to hear the commissioner bringing in the issue of accountability among government colleagues. And then, of course, a good health care financing system. So having the Plateau State BHCF, I think we are right on course. And then good health service delivery, as well as performing a well-performing, we can see the adjective there, a well-performing health workforce, which are sufficient, fairly distributed in terms of mix, and they are competent, responsive, and productive. So it is not just having the health workforce, but of course a quality health workforce. And then access to essential medical products, vaccines, and technology. Plateau is one of the states that is hit by the humanitarian crisis. So I think we need to take this point very seriously in terms of accessibility of some of these commodities to those who are affected by the humanitarian crisis. Then a well-functioning health information system, which provides us with analysis and then, of course, dissemination of results. So this is just some kind of conceptual framework. Theoretically, when you have good health system building blocks, what are the action domains that you need to take care of in order to be able to achieve the impact? Of course, the impact overall will be to reduce health risks, improved health, equitable health outcomes, and improved financial protection, which is what our immediate goals are as far as achieving the universal health coverage is concerned. So health system reforms, what are the specific health system reforms that is needed of us as a governing body in the health system of Plateau State? We need to leverage on the State Council of Health and, of course, the SWAP approach, which are part and parcel of this convention here. And then a sound health system policy, improved interagency and department synergy, which is often a missing link in most of the states. So we need to harmonize and have an improved interagency collaboration. Priority-oriented health spending, effective and efficient resource mobilization, and then healthcare commodities and services that are equitably distributed. We can see we are highlighting it in green here for us to be able to understand how serious this is. Then requiring a more integrated response that recognizes the interdependence of each part of the health system, of course. So health system reform targets, we can see the targets in red. What do we need to do for us to be able to have a decreased out-of-pocket expenditure? Of course, it is by looking inwards at the health expenditure. Then for you to be able to have a sound state social health insurance and health trust fund, you need to have a very good quality health financing system. And then how do you have regulate some of the concerns is by having new policies, of course, that will align with the objectives of the universal health coverage. And of course, how do you improve the consumer behavior? Of course, is by having health promotion activities and creation of awareness by communities for them to be able to embrace better and seek better health care in the communities. Then we also need to reorganize, like I said earlier, of some of our agencies for us to be able to have a well-harmonized and constituted agencies that will, of course, lead us to where we are expected to be as far as universal health coverage is concerned in Plateau State. So, road to achieve this, we look at resilience, of course, the ability to withstand shocks like during conflicts, which we have taken a long hour trying to understand how the government was able to, cope with the incessant acts of humanitarian crisis in Plateau State. And of course, inclusivity, which is usually accessible services for all population, regardless, of course, of your tribe or your geographic location or whatever. Then equity, we need to reduce out-of-pocket expenses. Of course, we saw the huge amount of out-of-pocket expenses that we see among populace, including all of us that are seated here. Then we need to also plan some form of sustainability plan where we look around for local financing and, of course, community ownership. So these are some of the roads to where maybe if we get these things right, we should be able to to fall along the path of having universal coverage in Plateau State. Now, this is just looking at Plateau State. When you look at disease outbreaks, usually you have poor quality of care in health facilities. When you have that, it's usually due to inadequate funding, high infant maternal mortality rates, suboptimal routines. So these are some of the challenges when you have such kind of concerns. And then, of course, these are some of the issues with RIMCA. You have low proportion of ANC visits. You have poor documentation. So these are some of the challenges which I don't want to repeat because I have stated some of them earlier. Now, the HSS building block, of course, we know we have 5 or 6 of them, where we have service delivery as the very pertinent building block, health workforce, health information system, medical products and vaccines, and then health financing and leadership and governance. So we need to have that for us to be able to have people-centered universal health coverage. For service delivery, we need to increase access We need to make available distribution of these services and then improve RIMCA and quality of care. Then for the health workforce, we need to have a good HRH plan and then increase their number, of course, fair distribution like I mentioned earlier, and then human resource for health management policies and strategies. You know, we have a lot of people retiring without people covering up those spaces. So we need to look at those plans and ensure that we look at them in that direction. Then disease surveillance, of course, when you look at the health information system and use of data for action, as well as evidence-based intervention through research and what have you. Then data management and monitoring evaluation system. And then for the medical products, we need to have adequate supply of vaccines, drugs, and other health commodities, as well as efficient procurement of supply chain management. And then for health financing, we have stated this earlier, that we need to have at least minimally increase our budget from, is it 1.5 to about 15% for us to be able to have the basis for a universal health coverage in Plateau State. Then of course we have leadership and governance, which has to do with sustainable people-centered policies and strategies, as well as effective oversight and accountability of the workforce. So some of the sustainability plan, we can achieve them through continued commitment, which we have seen from the governor here giving us assurance, and then local partnership and domestic resource mobilization. We need to do more community engagement. You know, we have all these rich people, we have philanthropic individuals that are ready to support us in some of those plans. And then we should be able to have a robust contributory health scheme, which I know at least they are doing their bits in that concern. And then community participation, of course, and ownership. Also, private sector engagement, very important for us to have a good sustainability plan, multi-sectoral collaboration, changing the knowledge and attitude of people through creation of awareness, of course, and implementing new policies that support each of the health programs that will impact the health of the people of Plateau State. So some of the recommendations include develop and implement policies, guidelines, and operational frameworks for primary health care, increase domestic and external resource mobilization, increase health budgetary allocation to 15% or even more. Of course, when we look at the Abuja Declaration, we understand that all the governors declared to increase their health budgetary allocation to 15%. So we don't know where this promise is as far as the state government is concerned. And then, of course, create an enabling environment to encourage donors and local partners to come with their support. Then improve human resource in terms of recruitment, retention, motivation. And then strengthen the state contributory health and social health insurance scheme. Also implement people-centered and evidence-based interventions, promote gender equality and women empowerment, as well as educational reforms that improve the literacy level of Plateau State's people. So in conclusion, in order to achieve the state, national, and international goals, including the MDGs and the SDGs, there should be more effective investment in health system and services. While more resources are needed, the government and partners use the existing resources using innovative ways and harness focusing energies of communities and non-governmental organizations. There is no guarantee that the poor will benefit from reforms unless they are carefully designed. And this is the end in mind unless the efforts of other sectors are put in place to achieve better health interventions. So thank you on behalf of WHO. This is all I have. So these are some of the references for your checks. Yes, thank you.
Please, I think we can do better. Let's put our hands together for her. She was talking about the professorial lecture that came before her, and I think we should also call her a professor. Professor Asmai Zainat Kabir. So please, let's put our hands together for the newly. That was very astute and straight to the point, and I believe that we've been taking notes. I believe that we've been wondering in our heads. So we have opportunity right now before we call on the Plateau State Cultural Troupe for their playlet. We have 5 minutes. In case there's anybody that has been taking notes and is, pressed to ask questions, the 2 last speakers that just spoke. So can we just have that moment now in the next 5 minutes? There'll be a microphone that would go. So we just have one from both sides so that we save time, and we'll move on to the next one. Then we will come back for that again. Do we have anybody here? Do we have anybody here? So that we pick just two. Anybody that has a question from what has been presented? All right, we have one over here. And then this other side, do we have any other person here? Okay, so I think moving forward, the speakers should focus on this other part, because these are the part that are simulating even much more. You know, our professors will say that if you don't ask questions, it's either you don't understand or you... Okay, so we have one person that has saved everybody, so we'll focus on the whole class. That's better. All right, so can we have you, sir? Up there. Sorry, can you wave your hand so that the mic will get to you? Can you wave your hand so that the mic... Oh, very well. So let's keep it as snappy as possible, quickly.
Okay, thank you very much. My question goes to the first speaker, the professor. Now, that was a very good presentation, highlighting the healthcare needs of crisis-affected populations. We are all aware that at the national we have NEMA, at the state we have SEMA. I'm picking him on when he said, the coordination and governance. Now, sir, Prof. Sir, in the needs of crisis-affected population, where is the place of LEMA here? When I say LEMA, I mean Local Emergency Management Agency. I ask these questions because a very sizable number of our local government chairmen here, and anytime there is crisis, our people at the grassroots are the worst hit. So the professor mentioned SEMA. I didn't hear you mention LEMA. So where will be the place of LEMA in healthcare needs of crisis-affected populations? Thank you very much.
Okay, is there anybody that Prof has ordained to answer the questions on behalf? Oh, Professor Zina, they said you're the newly professor. Yes, but I think that question would be directed to Prof because he just stepped out, so he would answer that when he comes back in. Yes. So should we move to the next person here? Yes, sir. Yes. Your question is noted and it's going to be answered. Yes,
okay.
Sir.
Thank you very much. I appreciate it. Good afternoon, everyone. My question would be, very often, what we do is always to get models that are designed for, maybe then they are.
Sorry, sir. Can you speak to the mic so that we all can hear you?
All right. Sorry. I said very often we get this recommendation of models that have been designed to work in the West, and they transfer it to us. And we discovered that the context here is quite different from what. That's why none of the models that's been recommended for us has worked in Africa. So, does she think would adapt or adopt these recommendations successfully given our peculiar context?
Okay, so are you directing it to WHO? Okay, very well. So, Prof, it's directed to you. Sorry, we're going to take just two.
Yeah, so thank you so much. If I
Just
understood
two,
your question right, you
Sir?
want me to give you an idea of how we contextualize these reforms we have into our own current situation in Africa, right? In Nigeria. Okay. You said religion and ethnicity. Yeah. So I understand you. Actually, if you look at my presentation, it's a universal presentation, of course, like you rightly said. However, there were some key information I provided, especially in terms of community engagement. You understand? Because that is one way, that is the gatekeeper to some of these our concerns, which most times we leave lacking whenever we are making reforms. So we need to build on community engagement for us to be able to build up. So it should be a bottom-top approach rather than sitting in the offices and making reforms and policies that will work for the people of Plateau State or the people of Nigeria or Africa. So I think that is one step to look ahead. So when we provide universal context, of course it's for you to marry it, build on it, and then see how you can devise means of getting this dependent peculiarity of your state. If you notice, of course, Plateau and other states, Benue, you know, the Borno, and they have their own humanitarian rights. So we are trying to make reforms and policies. We need to look at those concerns rather than look at what is in Lagos or what is. So even within Nigeria, we need to contextualize states and what is the prevailing situation in those states. So I agree with you that when we make these presentations, we do that. And that was what gave you a brief overview of the situation analysis of Plateau State, so that we'll be able to see how we can marry both and then moving forward. So community engagement is very important, and I think we need to look at it.
All right, thank you so much. There's an observation before we take on, you know, the question you did mention about the NEMA response. At the local government level, we would take an answer from the chairman of local government. Yes, so let's have you, sir.
Thank you, Prof. You, in the course of your presentation, you cited, if I heard you clearly, was it 540 as MMR in Nigeria? Eh? I want to, I'm afraid the figure may not be accurate. The latest publication, the latest 2025, shows that Nigeria is the leading country in the world when it comes to MMR, and it is 1,047. So please, sir, this is that we have a lot of students here. The next you are going to hear from them, it was WHO that cited this. So thank you very much.
Sorry, can we just maybe note them down for want of time? Thank you so much. So it's just to prick up our minds as regards that, and then we're going to come back. Sorry, can we have the microphone quickly to have our local government chairman also still respond to the structure they have when it comes to emergency response that the first person asked. Yes.
Let me recognize the commissioner.
No, sir, just
and
also.
I still remain Kemi Nicholas. The emergency response starts from the local government because that is where the emergency starts. Because 774 local government, all over, it's what is the component of Nigeria. 17 local government, the component of Plateau State. And therefore, any disaster that is happening, whether nationally or in the state, it has to be in a local government. And therefore, we have the three set of emergencies, agencies. One, the local emergency, which is the local government. We have the SEMA, which is the state, and we have the NEMA, which is the federal. And therefore, we are the first people in the affected area that do the reporting. And this agency is being managed in the local government by the deputy chairman and the director of social services and other directors, where there are emergencies that affects either flood or any other thing. But in case of disease control, it's another line. That's PAC. Then we have the M&E, we have the Director of Disease Control and the Director of Primary Healthcare. If it's for disease control there, if it is for emergency in terms of flood and other
State Cultural Troupe.
Kai, this is really sad. The situation is very bad. Mr. Commissioner, you see every year, so many of our people die due to lack of essential medications. We need to set up policies that would enhance the affordability and availability of these drugs for our people. If not, I foresee danger, I tell you. Or what do you think, my brother?
Yes, my sister, you are right. You are very right. You see, I've checked firsthand, and I see that most of the drugs are not, and often not in the stock. But I don't know, and they are not affordable for the patients. So I don't know, how can we do about it, Mr. Commissioner?
I assure you that we are working on it. Yes. It's complicated somehow, you see? Yes. We need to balance costs, supply chains and regulatory frames so that medication can get to every nook and cranny of this country. If not, our people, will suffer a lot of damages. Yes, I tell you, we are working on it. Yes.
I've been searching for months, but the medication I need are too expensive. I'm now forced to choose between treatment and food.
We can't wait. We need action. Let's raise our awareness and push for change. All right, my brother. Innovative solution like generics and biosimilars can increase access. We need to invest in research and development.
Accessibility is key that we need to ensure medicine reach remote areas.
You are right, my sister. We all know the importance of access in our community, and we are working on our pricing strategies and partnerships to increase availability of drugs in our society.
Yes. Yes, because we need medicines that are affordable and ability, so that we, the elders, will give a portion of land to build a primary health care, so that our people will not suffer without them. Let's work together to find solution.
Yes, you know, access to essential medicine is our right as citizens. You know, we all need to come together and help each other to access and to receive every good health care that we deserve. My people, you know our government, you know the logo of our governor is to talk and do. You know he's doing it, so we will not leave him alone. We'll all come together and join our hands. So I call on the religious leaders, traditional rulers, corporate bodies, and everybody should all come together so that we'll join our hands and make sure that our health care is properly and effectively done. Please let us all join our hands together so that we'll achieve this. Thank you, my people.
Thank you. Thank you. Thank you very much. Thank you so much. So colorful, so energetic, and the message is very clear. Thank you very much, the Plateau State Cultural Troupe, and we really appreciate that. Please, let's put our hands together for them again one more time. To take us to the next, without waste of time, ladies and gentlemen, we've had some of our distinguished panelists and very, very astute people here waiting since 8 o'clock, and we would want to have that panel discussion at the moment. So to take us to the next level and to moderate this, ladies and gentlemen, she's a medical doctor with a fellowship in community health of the West African College of Physicians. She's a professor from the University of Jos in the Department of Community and a consultant with the community health physicians of the University of Jos Teaching Hospital. She has a special interest in environmental health and also public health laboratory, quite a number. Ladies and gentlemen, she's an astute professor. Let's put our hands together for Professor Chundung Maina.
I'll take the permission of the Commissioner of Health to stand on the existing protocol. I think before I take my seat, I will call on those who will be with me this afternoon to have this panel discussion on funding healthcare in a resource-constrained setting. I'll call them in the order in which they are listed in the program. So we have the Director General of the Plateau State Contributory Healthcare Management Agency, Dr. Kwande Dawal, who was recently appointed. Please, let's give him a hand as he joins us here. Then we have Dr. Maurina Sunwar, representing the State Ministry of Health. She is the coordinator of the sector-wide approach. Also joining us will be Dr. Musa Madi Wade, the State Coordinator of the WHO on this plateau. He is also the Health Response Coordinator for Humanitarian Responses on the plateau, and he also heads all the partners that we have in Plateau State. Let's give him a round of applause, please. Joining them will also be Professor Ayonumbe Usar. He is a professor of health economics with a focus on health economics and health systems. He's in the University of Jos. He has also been a consultant for the second National Strategic Health Development Plan of the country. You're welcome, sir. We also have with us Professor James Damen, MNI. He is the Dean of the Faculty of Health Sciences and Technology, College of Health Sciences, University of Jos. He will also be joining us. And last but not the least, we have Professor Noel Wanang, a very well-known academician on the plateau. He is a professor of pharmacy, Department of Pharmacology and Toxicology in the University of Jos, former Secretary General of the West African Postgraduate College of Pharmacists. You're welcome, sir. I think now that let me wait for Prof to be seated, then I'll sit down. So you're all welcome today. So the procedure will be, I will direct some questions to them, all to help us in understanding this topic, funding healthcare in resource-constrained settings. I'm sure from the first two presentations, we have seen that funding is a major issue in healthcare. As much as possible, I will request that our panelists try to ensure that their answers are focused on the plateau. I know that we have general problems in the country, but we would want a situation where, since we're here to talk about health on the plateau, that will be our focus. So I'll direct my first question to Professor Usar. In your view, Prof, what are the biggest healthcare funding gaps in resource-constrained settings presently, especially on the plateau? Please, do we have another?
Thank you.
Okay, fine.
Yeah, thank you very much. To this conversation going, I think I need to first of all define what we mean by resource constraint in a health setting. So for health sector, when we say resource constraint, what we mean is that there is shortages or deficiencies in all the the building blocks of the health system. But we put more emphasis on funding, human resource for health, infrastructure, technology, and the other physical things that we see in hospital settings. So with that perspective, we can see that the biggest problems of health funding or financing in Nigeria, perhaps which is the same problems that we have in Plateau State, we stem from all of this. There's human resource shortages because of the migration of highly qualified health personnel to foreign countries. The allocation of funds for funding health services is grossly inadequate. We just heard from the WHO rep here that although we all agreed in 2001 that we would allocate 15% of our budget to health, as of today, that is a far cry. There's no state, even Plateau State here, that allocates more than 5% of the state budget to health. That is another area. And then when we go to the hospitals themselves, we find out that the thing required for health care delivery are grossly inadequate. And so for us, everything is grossly inadequate. So I cannot say that one thing is the most acute, but the entire health system is under-resourced. And so everywhere there is shortage in financing for health. Thank you.
Thank you very much. At this point, I would like to say that the fact that the panelists are here does not mean there are other people who don't know more than them. At the end of the panel discussion, we will still take questions and comments from the floor. So please, if you have comments that are related to the questions that I'm bringing up, or you want to add, please write them down and note them. We will take them at the end of the panel discussion. So thank you very much, Prof. Usar. The summary of what he has said is that there is shortage everywhere in the health sector. All right, so Dr. Mahdi, what are the main sources of healthcare funding in resource-constrained settings, and how sustainable are they?
Thank you so much, Prof, for these questions. I think my question is the most easiest one, because identifying source of health funding in the resource-constrained nation or states is very easy. We're all Nigerians. The number one source of funding is the federal allocation, states, and of course, local government. They are the one funding the health sector in the country. However, the funding is quite small because none of the states, maybe few, two to be specific, have made the Abuja Declaration. Most of the states in the country did not achieve that. Coming down to the states and local government, there is some level of financial constraint. Another source of funding is the funding from the health insurance scheme. We're all aware that the National Health Insurance Agency and of course the State Health Insurance Agency are also contributing to the funding of health in the country. However, the funding is also very limited. I must commend Plateau State government because the coverage for health insurance on the plateau is only 8%, and Plateau State has contributed to more than 50%. I think it's a great achievement. Another source of funding is the support from donors and, of course, some partners. The issues we're having there is that support from those are project-centric that has a timeline. Once the project is completed, that intervention will stop. Another source of funding is the out-of-pocket expenditure. More than 70% of people in Nigeria are using their money in their pocket to access services as well as pay for diagnostics services. We need to define a means of reducing the out-of-pocket expenditure. Another sort of funding as a country and Plateau State has to do with the private sector. In Plateau, we have more than 400 private clinics. And you know, accessing those private clinics is very, constrained because you must have the required economic capacity to access those services. Another key source that is common in the country, but WHO and other partners are advocating is the community-based financing, which of course innovating or give up some modalities or mechanism that communities themselves will mobilize resources for health is very, very key. The other part of my question is how do we sustain them? It's very easy to sustain them if there is political commitment and political will. We can only sustain it by adhering to the Abuja Declaration, by increasing our budget line, not only in the state as well as the local government councils. We should also work with partners to realign their support to the health priorities or to the state priorities. Their support should be toward improving the health system, not a project-centric. With the swap approach, I think this issue will be addressed. Another sustainability is to embark on this community-based financing. Engaging community from planning and of course implementation of health intervention will go a long way. The health insurance scheme should be expanded beyond formal. Let the informal also be considered. I'm happy to note that in Plateau State, Move One Care is also providing services to those vulnerable populations, including retirees. But I think the non-formal sector should also be considered. Thank you so much.
Thank you so much, sir. I think he has touched on so many aspects of funding. So he stressed the issue of political will. Sorry, you wanted to? Yes, please.
I also just wanted to lend weight to what he has said. I would rather have preferred that he said what's the most important source. He started from the least important, because we do know that health funding in Nigeria, like the WHO told us, 70% is from out of pocket. And so to place state government, federal government on top was like, not putting it the way it is. We fund health in Nigeria from the pocket. Sorry, that's just what I want.
All right, so opinions differing here, although they are all sources. So, well, I was since we've mentioned that political will is part of, because I think even when you were speaking, Prof. Usa, you talked about the fact that there needs to be provision of equipment, provision of consumables within the hospitals and, for healthcare servicing. And I think the bulk of that, if I'm not mistaken, actually comes from the funding from the federal and state and local governments. But in terms of accessing healthcare, I will agree that yes, there's a lot of out-of-pocket expenditure. So with that background, I think I would like to ask Dr. Maureen Asunwa, who is here as a representative of the State Ministry of Health, with the limited resources that the state government has, how do you think they can prioritize spending when it comes to health in the states?
Thank you very much. With the limited resources, the first thing is to start with the grassroots, with primary health care facilities. We know these are the facilities that are the closest to the community, and they have actually been put in place to provide care as the first line. Strengthening the PHCs is very key. And when we are talking about strengthening it, WHO said, most of the things we've had are supports from partners, but they are not systems in place to strengthen. In order for us to begin to move from support to strengthening system, we have to begin to look at the structure. Because if there is no structure in place, then you cannot even deploy workers to that place. So the structure has to be existing. And apart from the structure, we're also talking about equipping those facilities, making accessible, making them ready to deliver services. We're also talking about of drugs, avoid stockout at facility. Then after all this, as the stage has been set, then we now put human resource. When we are putting the human resource, we also need to consider the quality of the knowledge that those human resources have to provide those services, as well as even training and retraining those health workers. So considering the constraints we have, these few steps would further help the healthcare system begin to move from support to a strengthened system, because this way we know that it is sustainable. When we now begin to also look at external source of funding, we can begin to also strengthen the newborn care. For example, our PACs do not have the capacities at this level in Plateau to provide newborn care, because they don't have the resource, they don't have the equipment, they don't have the human or knowledge. And so in newborn emergency, we're thinking of referring them to a secondary facility. And predominantly, most of our care or most of the partner support goes directly to the PHCs. They are not, the secondary facilities are not really factored, but these are people who are expected to provide secondary support to the PHCs. And so we need to begin to expand our care to not just the PHCs, but also to the secondary facilities and the tertiary facility. Because at the end of the day, when we're talking about the referral system, these three steps of care are all interwoven to provide quality of care within the Plateau State. Thank you.
Thank you so much. As a public health physician, I think I'm inclined to what you have said. And I'm sure the ES of the Primary Health Care Board is very happy to hear that she's requesting that funding should go most to the lowest, well, not the lowest, but the first tier of our primary health care system. So, and I agree with you, because that is the one that is closest to the people. So thank God that our Executive Secretary for Plaskema is here. Oh, sorry, our DG for Plaskema is here. And we believe that your agency is a part of funding for that level of care and all levels within the state. So I think we want to hear a little about how your financing is able to assist healthcare, and are there other innovative financing models that you think can work in situations or settings like ours?
Okay, thank you very much. So regarding the contribution of Plus Chema to strengthening and providing an avenue for sustained funding to the primary healthcare level, I'd like to say that right from inception and the commencement of operationalization of our programs, we have continued to sustain funding to primary healthcare centers and, of course, accredited secondary facilities across Plateau State. Now, some of this funding has come from contributions from government as well as from residents of Plateau State. We have also sustained funding to primary care centers using funds that have come to the agency through the Basic Healthcare Provision Fund. And I'm sure that our contribution has helped in no small measure in strengthening financing to the primary healthcare centers and has really opened up a new vista of fiscal space for health at that level of healthcare. Now, beyond that, it is also important that we look at avenues for innovative financing for health system within our local context. Now, innovation, I would like to look at it in the light of new systems of funding. As a health financing institution, at the agency, we have been really involved in brainstorming sessions on how we can really look at new avenues for funding healthcare in Plateau State. One of the areas that we've really looked at is, well, before that, it's also important to look at the context within which we operate. Previous speakers have actually talked about the fact that, in the first place, budgetary allocation to health is suboptimal because it falls below the Abuja Declaration, which stipulates that 15% of our budgetary allocation should be to health. Again, we would also want to look at the level of funding. Now, Professor Usa talked about 70% of financing for healthcare coming from pockets of individuals, families, and communities, which is out-of-pocket expenditure for healthcare. That modality of expenditure for healthcare is largely inequitable, and it is not associated with improved outcome for healthcare. Another third contextual variable that I'd like to look at, especially as it relates to Plateau State, is the fact that there is widespread endemic poverty in our state. The recent multidimensional poverty index assessment places Plateau State as having over 84% of our population falling below the poverty line. That means that individuals are largely constrained in paying for health care when they do have need for such access. That would really place a huge deterrent for the state in achieving universal health coverage. Now, to go straight to the point, it therefore means that there must be increased public expenditure on healthcare. So government must increase its expenditure in healthcare. And I'd like to look at it within this space. We must design and implement programs and policies that will target the poor and vulnerable within our environment. Luckily for us, at the State Health Insurance Agency, we have what is called the Equity Health Fund. By the law establishing the agency, a minimum of 2% of the consolidated revenue fund of the state and that of the local government is expected to be earmarked for the purposes of providing health care for the poor and vulnerable in our society. However, that has not been implemented. Although the state has really tried by way of providing counterpart fund for the Basic Healthcare Provision Fund, which has opened an avenue for us to enroll some category of poor and vulnerable people in our environment, that aspect of the net would need to be expanded. Now, beyond expanding it at the level of the agency as well, we must be able to design innovative measures of using the Equity Health Fund as it comes to the agency. One of the measures that we'd like to look at is integrating it with some form of community-based health insurance programs, where communities are able to get some premiums and they take care of their primary care, okay? Because what we do is to actually purchase a basic minimum package of health service, and that includes primary care as well as secondary care. So if communities are able to take care of their primary health care needs, then the agency can actually use the Equity Health Fund program or funding to actually take over referrals, at that level. Another way to expand the fiscal space for health is to actually integrate elements of innovative taxation, to expand the pool for funding available to the agency to procure health, especially for those that are considered to be poor and vulnerable in our environment. And of course, that would include taxing goods and commodities that fall under probably these three categories. Number one is the area of sin taxation. Sin taxation in quote, that means taxing elements that are considered to be deleterious to health. For example, are we able to add additional taxation to commodities like tobacco? Are we able to also earmark taxation from alcohol consumption? Are we also able to earmark taxation from certain sugar beverages and ring-fencing that financing for the purpose of financing health insurance for the poor and vulnerable in the environment? So those can actually also be of help. Are we also able to look at areas of looking at the business environment that operates within our context? Probably the agency could actually work with Internal Revenue Service or the Ministry of Commerce and Industries and stratify businesses operating within the state. Those who are in the top echelon of operations based on their annual returns, are we able to get a percentage of their profit into the health insurance pool for the purpose of providing health insurance for the poor and vulnerable in our environment? That's one aspect of expanding the fiscal space for health. Another channel that I also want us to look at by way of innovation is, can we be more, well, this has already been practiced, especially with the coming of the swap approach to health systems implementation. Donors, when they come to implement here in our state, we should discourage verticalization. When you bring your funds, you don't tell us what to do with the funds. You don't come and tell us that these funds should be family planning, these funds should be for malaria. Can we just put the funds in a common basket and see that it actually expands overall access to healthcare rather than verticalizing to a particular program? That, in my estimation, would really improve our health outcomes rather than particularizing it to a particular side of program implementation. Now, there are several other modalities. Now, within the poverty, our environment too, we have politicians who continue to do empowerment programs. Today, you see a member of House of Reps coming to do empowerment by buying grinding machines or motorcycles for people as a way of empowering them. Can we link that to some provision of health insurance to those people that are being provided with such empowerment programs? Now, I think these few points and some others that when we look at very closely would really leapfrog Plateau State from where we are to a journey directed towards universal health coverage. Thank you.
Thank you so much. I believe that we're going to see greater things from you with your new appointment. If I may say, this sin tax, can we tax Goskolo? Maybe it will, it will prevent some of our youth from going there. And I think some months back, NMA brought the business community and the healthcare community together to discuss healthcare funding. I really hope that NMA is following up on this because it touches on part of what you have said. But you also talked about the poverty level on the state. So I'm just wondering, Professor Wanani, if you can help us. How do we ensure that these funding mechanisms that are being mentioned here will not exclude the vulnerable populations that we have, not just in terms of poverty, but even those who have some forms of disability, and all that? How can we actually ensure that they are not left out?
Thank you. I wish I could also ask you a question. When you say vulnerable group, what does that really mean? But don't worry, I'll come to that. Growing up, there used to be this folklore. And the folklore is like, there was a celebration in a house, two dogs moving together. One of the dogs is from that house that there's a celebration. And the other dog told him, "You are enjoying, Then the second dog asked, "Why did you say so?" He said, "Because every day they are celebrating in your house." And then he replied, and his reply was, That is them celebrating. If the food is mine, so Ajeshi Akasangeni, put it on the ground so that I will know that this is my food. Meaning each time they're celebrating, they celebrate on the high table, on the table, and eat everything. There's no remnants for him. But to an outsider, he thinks he's always enjoying, benefiting from the remnants of the meals. Now this, my link, folklore, is related to what happens between the urban centers and the rural centers. Each time we meet here and we discuss beautifully dressed, colorful environment, we talk more on the city, the city, the city. Nobody talks about the village person. I'm happy local government chairmen are here. I'm happy some of them came with their supervisory councillors on health. But I will tell you, if I am to ask them the basic statistics, how many of them have the record of the rural people, those in the villages? A lot of them will not have. There is a big lacuna, a big gap on research. Number of persons in the village, the vulnerable ones, the disabled ones, those records do not have. Most of our politicians, they may have the records of those that will give them votes. They have records of how many people, Plateau State, 4.7 billion, just North 600 and this 1,000, just South this 1,000, without going to the nitty-gritty of other indices like health. Number one, Plateau State lacks data. We do not have data on information about the number of persons in those villages, what they do. I agree. One thing that is common and repeatedly said, even from our Professor Zainab, she said our budgetary allocation is too low. Let us begin from budgetary allocation. If we really want the vulnerable groups to benefit, we must work on the budgetary allocation. Working here does not mean you just give a blanket budget across board based on population or size. No. Direct your budget based on needs. Let us look at the women, the children, the maternal, the vulnerable groups, the elderly. Let us look at also the, what do you call them? Disabled. What records do we have about those things? Having settled that, we should also come and consciously talk about community-based programs. Training. How many of us have that record of those that go to the villages to train? Let us consciously increase community health extension workers, bring them into the fold so that they will go to the villages and educate them, advocacy and all that. Most times on the plateau, we don't do it. We allow those that have the opportunities, churches, mosques, to be the ones that are advocating for health. And sometimes they don't do it rightly. I'll give you an example. I had an experience in one village. And in that village, it was a family planning program. In that village, they were talking about family planning, control, and the use of condom. And the church people, of course, when they got there, the person educating the crowd was demonstrating the use of condom. Remember, I said it's a church. The young man removed the condom and inserted the condom on his thumb and told the villagers that once you will have this inserted in your thumb, when you have sex, it's a barrier, blah, 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 and all that. 1 year later, when I found myself in that environment talking about advocacy, they chased us out, that we are liars. That we told them the last time that the use of condom stops is part of the family planning methods. Unknown to us, the persons that were there, the males, collected the condom in good faith. While they were having intercourse with their wives, they inserted it actually on their thumb. And they concentrated on their performance. At the end of the day, the woman got pregnant. And they now blamed it on the woman that they deceived them. Why am I giving this narration? Once you have trained persons, access to such information, advocacy will be there. And remember, the villagers will always tell you. I was just discussing with my professor colleague, and he said, high number of births are always found in the villages. Because as far as the poor man is concerned, sex is a way of creativity. He has no money to do anything other than sex, high level of births. We need to consciously develop our child, consciously integrate our villagers into our policies. Most of our policies are top to bottom, not bottom. We just sit down and read textbooks. We sit down and look at what WHO is doing, look at what Oibos are doing, and we hook, line, and sinker, transfer it, and we think those things can work. The villagers are not involved. When you bring them into policies, they will own the policies. They will be part of the policies. Looking at this organization, where are the traditional doctors? Where are the traditional medicine practitioners? Don't you think that they have a high patronage in the villages? The whole of here, I don't know whether there's anybody that's a traditional medicine practitioner, herbalist here, none. We are only pretending the bulk of our villagers are patronizing these traditional medicine practitioners. How can we educate them to change those their bad, terrible, obnoxious practices? Have we consciously thought of doing those developments? If we can do that, we are involving the vulnerable groups, we're involving people, we're involving almost every person's. Most importantly, accountability and transparency. Do we have any unit that monitors what happens in the villages? Do we have anybody that can give us the level of implementation of our policies? And that is where I come back to the dog and occasion indices. We can sit and say the family that celebrates every day, their dogs are enjoying, but the dogs are suffering, are starving because none has dropped to them on the ground. Is there anybody that has consciously brought a report to us that they have monitored and evaluated what transpired in those villages? Is it nutrition? Is it maternal training? Etc., etc. By the time we do that, we'll be getting it well. Most importantly, the villagers, those in agriculture, we give them fertilizers at subsidized rates. Can we think of doing something true to the village man, subsidies to the village man, so that he too can have the benefits of what we're doing? Thank you, ma'am.
Thank you so much, Prof. As a true academician, he brought up the issue of data, that we need data to be able to focus on these vulnerable populations. And he has challenged the local government chairman and those working with them on training and also ownership and domestication of the policies that we have developed. And of course, he ended with the issue of accountability and subsidizing healthcare at that level. Thank you so much, Prof, for your contributions. Our time is fast spent, but I will just quickly like to ask Professor Damen, MNI, if you would just give us, if you are asked to implement one bold healthcare financing reform in the future for Plateau State, having listened to them or even from your own insights, what would it be?
Okay, thank you very much for having me. And we all agree that we have problem in the health sector. There is no available funds in the health sector. And so there is need for us to actually come up with reforms. And for me, from my background as a medical laboratory scientist, I believe in evidence-based. And so, as also a member of the National Institute for Policy and Strategic Study, the best solution or the best reform that we actually need in our state to make funds available for solving the health needs of our people, most especially our people in the local government, in the rural communities, is actually for all of us to agree that we introduce health tax fund or health trust fund. From my background from the university, we all know the ETF, which we now call it TED fund, has contributed immensely for the development of infrastructure and other amenities in all our tertiary institutions. If today there is no TED fund, we will have a lot of problems in the tertiary institution. And TED fund was actually, it came as a result of struggles of ASU when they discovered that government was not paying enough attention to the educational system. And so it was educational trust fund, and then it now metamorphosed to TED fund. And all of us, there is no tertiary institution, whether state, federal, and also private tertiary institution, that you will go and you will not see a building, you will not see equipment, you will not see a lab that is provided by TED fund. And so I am saying this because Senior Executive Course 19 of the National Institute of Policy and Strategic Study conducted a research, and they advised federal government that, look, the best way for us to have available funds in the health sector is to actually introduce the Health Trust Fund. And I want to also put here on record that we have some states, Lagos, Kano, and others, that they have introduced it, and it's working for them. And so as a state, we have identified that our major problem in the health sector is that the needs of the people are not properly met because of funding, and we need to do that. I am also of the opinion that we need to also strengthen Plashema. Very, very important. I have the privilege of also traveling out of the country and doing a lot of study. And what organizations similar to Plashema, what they do is not only concentrating in just providing drugs for patients. They also try to see what can we do to even the institution so that it can also prevent people from, getting sick. So that you can now, the money you have will be enough for you to actually reach out to the rural communities. And outside the country too, I have also discovered that organizations like Plashema, they invest a lot of money on research. Bringing people together and doing a lot of research. And so I am of the opinion that Plashema need to be strengthened so that they can also expand the scope of what they are doing so that the rural people can also be looked at. And I also want to submit that we also need to look at even the leadership structure of the health system. Let us make it to be more inclusive, and that will also go a long way in helping us. Thank you, and God bless.
Thank you very much. So a health trust fund. I think you're speaking to the right group of people. Please, let's not be tired. The reason for these technical sessions is to help us to begin to think as we consider the memos by tomorrow. So it's for us to begin to see ideas. How do we move Nigeria forward in health? So I think because of time, we'll just take maybe one or two very brief either comments or questions directed at the panelists. I can see one hand up already, a second hand there. My goodness, the hands are plenty. Okay, let me but please, you will not speak for more than 1 minute. So number 1 here, 2, 3, 4, and then 5. That's all we'll take, but please, 1 minute. Mention who you're directing your question to, unless if it's just a comment. We're supposed to, number 1 is here. Number 1, can you put up your hand? Can we give them? Okay. Please, let's keep it brief. Yes, I've given them numbers. Number 1. Mm-hmm.